Yes, ma'am.
Yeah, you're there, right?
Yes, ma'am.
Yes. Okay, so introduction. Namaste all and good evening. Today we have Dr. Dron with us. Dr. Dron is Assistant Professor in Department of Psychiatry, NAMO Medical College and Research Institute and NAMO Hospital, Silvassa. He has completed MD in Psychiatry and completed fellowship in psychosexual medicine in 2024. And he has also done PGDCH. And we are very fortunate to have Dr. Dron here. He's going to present a case study on treating a case of conversion disorder with hypnotherapy. So, Dr. Dron, over to you. Thank you.
Thank you so much, ma'am, for your kind introduction. Good evening, one and all. Respected senior hypnotherapist, members of AOH, and all my seniors and my colleagues. Uh, I'll just share my screen. Ma'am, can I get the request for sharing the screen? Okay.
Yes.
I hope my screen is visible and I'm audible.
Yes, yes,
Thank you, ma'am.
yes. Yeah.
So, good evening, one and all. I'll be presenting a short case of how I treated a young female with who presented with me presented in the department of psychiatry with a conversion disorder and how she was managed with hypnotherapy. So here is a case of Mrs. X, a 19-year-old female who is a first year BA student coming from a middle socioeconomic class family and Hindu by religion, resident of Palghar, and the history of was given by the patient and her father. The father's history was reliable and adequate, and she was referred to us from the Department of Neurology. When the patient presented to us, she came with the complaints of weakness on the right side of the body from past 3 to 4 days, episodes of unresponsiveness and tightening of limbs, and difficulty in focusing on studies for the ongoing since the past 2 to 3 months. There was a precipitating factor where she had hit the father out of an anger when the argument was going on between her parents. There were no predisposing factors elicited, and the maintaining factors was a constant ongoing dispute between the parents, and as she was unable to focus on studies, there was an constant building up of academic pressure. Coming to the history of presenting illness, so the young female was apparently doing well until around 3 to 4 months ago when she began experiencing intermittent episodes of unresponsiveness. This episode occurred following an apprehensive. Shortly afterward, she developed a sudden inability to move her right arm and leg, and the weakness lasted for about 1 to 2 hours and gradually improved on its own. This was a self-remitting episode. I'm sorry, and hence, and the episode there was no loss of consciousness, tongue bite, incontinence, or confusion after the episode. Over the next few weeks, the similar episodes recurred and it continued, particularly during the times of emotional distress, especially after the quarrels between her parents. During this episode, she would sometimes become unresponsive, or sometimes there was tight closing of her eyes and rigidity found in all her limbs. Her father described that she would even clench her jaw and sometimes would appear as if she was in pain, clenching her eyes so tightly but without any frothing, any abnormal jerky movements, or any uploading of eyeballs. Each episode would last roughly around 20 to 45 minutes, and they would subside gradually without leaving any residual weakness over a period of roughly about 4 to 5 days. After one such quarrel between her parent, about 2 to 3 days back, she got angry on the father, and out of that anger, she slapped him on his face. Following this act, she was so guilty about it that she fell down and was unresponsive for certain amount of time. Following which, she claims to the father claims to have father claims that she developed this right-sided weakness. She presented to the Department of Neurology, and then after the MRI and EEG were normal and inconclusive, she was referred to us, and we made the diagnosis of an psychogenic non-epileptic seizure or a functional neurological symptom disorder, that is a conversion disorder. The patient expressed worries about her inability to concentrate in studies, her persistent guilt over the incident, where out of an emotional reaction, she had hit her father out of anger. And she reported feeling anxious whenever her parents would argue and would fight, and there was a verbal argument. And she said she feels frozen during that moment. She feels she can't move or do anything during such times. Moving ahead, just clarifying negative history. There is no history of seizure in the family, and no history of any fever or any other functional neurological deficits seen. Premorbidly, her temperament was mildly anxious, very sensitive, and emotionally expressive. Attitude towards the stress was usually avoidant, and used to internalize. I'm sorry, internalize conflicts. Uh, Social relations, she would be cooperative and she maintain good relationship with her peers. Uh, she loves reading and music, listening to music, and grossly her premorbid functioning was normal. Coming to the precipitating, predisposing, and maintaining factors, there was no predisposing factors or no history of any trauma or any as such ongoing chronic medical illnesses. Precipitating factors, there was intense guilt and emotional conflict going on after hitting her father following an argument. And uh, the maintaining factor was that the ongoing parental conflicts and the building up of academic pressure, overprotective and emotionally family environment could be one such factor can be considered. It was a nuclear family of four members, wherein the father was doing a private job, was strict but still caring, and the mother was a homemaker and was also affectionate but also anxious. A younger brother studying in school. There were frequent marital disputes between the parents, as it was noted by the patient, and there was no family history of any psychiatric or any neurological illnesses to be found. Personal history: her birth and development were within normal limits. Education: currently she is a first year BA student, and had social relationships. She was very friendly and prefers a limited social circle, not sexually active, no substance use, and all her biological functions were well within the normal limit. The mental status examination, when she presented to us, she was groomed, appropriately dressed, cooperative, presented with an abnormal gait with a weakness, and eye contact was appropriate. Repo was established easily with a normal tone, tempo, and volume, and her speech was relevant, and her affect was appropriate, congruent with the mood. There were no formal thought disorders, no perceptual abnormalities noted. Cognition roughly was well within the normal limit, and the insight was grade 3, and the judgment was intact. Um, Not including many things in the diagnostic formulation, just a very brief diagnostic formulation. A 19-year-old female coming from a nuclear family with no prior sorry, psychiatric or neurological illnesses. Uh, Presents with recurrent episodes of right-sided weakness and unresponsiveness that were precipitated probably by a familiar conflict or quarrel in the context of psychological stress and normal neuroimaging findings. And her the premorbid functioning was well, functional neurological disorder or conversion disorder with psychogenic non-epileptic seizures. If we look at the psychodynamic formulation, then we see a lot of conflicts going on. The patient symptoms represent a symbolic expression of an internalized conflict and guilt. After hitting the father, she may have developed this unconscious guilt, leading to a physical symptom expression in the form of the muscle weakness, and the parental discord, which is acting as a continuous stressor, and the episodes, they do provide the episodes provide secondary gain by diverting the family attention towards her, and that might keep away from her the conflict. So this was the diagnosis made. When she presented to us initially, she was started on tablet sertraline 25 mg twice a day, tablet clonazepam, tablet olanzapine 2.5 mg in the night, and propranolol 20 mg in divided doses in the morning. The treatment was given for about 7 to 10 days, but since the response was partial, we had stopped the treatment, and then we decided to switch on to start her on hypnotherapy. Just explaining the sessions very briefly. The therapeutic sessions, in the first session, initial rapport building was done, a detailed history was taken. We also explained regarding the functioning of a subconscious mind, the concept of id, ego, superego, how the conflicts manifest, and our main treatment goal during for this was psychoeducating the patient for rapport building, and her evaluation was done using Hamilton Anxiety Scale and the Hamilton Depression Scale. With the continuous rapport building, the second session when in breathing awareness was done, so she was asked to sit on a chair and gently close her eyes. Hypnosis were induced by breathing awareness. She was then asked just to concentrate on the breathing and not to focus on thoughts, just to let the thoughts go. The entire session on breathing awareness was carried out, and there was no the patient enjoyed the experience. The patient experienced a sense of calmness following the session. In the third session, the hypnosis was induced by breath watching, and then a detailed progressive muscular relaxation was done. With the induction was done using the eye fixing technique, and post hypnotic suggestions were given to her regarding gaining confidence and calm with each session, and the strength returning to the right side, and also that she would gain a better motor control. And she was also advised to practice the sessions. For the fourth session, the neutral trance was done with a guided imagination, and she was, asked to imagine a beautiful neutral place wherein the cloud is taking her to the place, and she imagined going to a beach. Post hypnotic suggestions were given that she would able to achieve this level of relaxation and even deeper state of relaxation whenever she would come for therapy, and also that she would be giving better motor control of her body. She was for the fifth session, she was guided into trance by breath washing, and the deepening was done using Barnett's repeated induction technique. Then a quick PMR was done to deepen the trance. She was then given a dynamic imagery with a metaphor of butterfly. Following this, she was also given few ego strengthening suggestions for self-confidence, and then day by day her mind is developing conviction that it can overcome all the limitations and weaknesses, and by the strength and potential that she possesses. And then the trance was gradually terminated. And in the sixth session, she was given another session of relaxation and ego strengthening for achieving relaxed and blissful state of mind. Following this, she came back to us after about 10 days, and we carried out another two sessions of another one to two sessions of ego strengthening. After about 3 to 4 weeks, she was in total remission and was doing well and was functioning had improved, and she was functioning well. So thank you.
Okay. So, anyone would like to ask anything? Any questions? Any questions?
I think we should first of all congratulate Dr. Drone. It was an excellent presentation. I mean, um, it always feels good when, uh, we can actually bring about changes in person's life by using ego strengthening and everything. So I have one question, like the whole hypnotherapy sessions were focused only on ego strengthening. Were there any like exploratory things done, like maybe ego
Uh,
state or
no, ma'am. Exploratory things, any SIC or like ego states were not explored, ma'am.
okay. And she fully recovered with ego?
Yes, ma'am. She was
Um,
doing well.
great, great.
So, yes, it was, very well presented. It was very step by step, as Sir has taught us, and in a very detail. I know psychiatrists always focus more on the diagnosis, and it was done so wonderfully. Dr. Drone, I would like to just know that according to you, which session helped her more? Like after which session you felt that उसका response बहुत अच्छा लगा, उसको बहुत अच्छा लगा, kind of thing. ऐसा
Probably
कुछ
I would
option
say
बताएंगे?
session four, or the dynamic imagery session, I would say, wherein she felt more confident and she was very eager to do further sessions following that.
Okay. And just from my understanding, you did dynamic imagery pehle and then you did ego strengthening. The
Ma'am, only the
butterfly you did the
suggestions,
first?
yes, yes. Butterfly was done first. The only suggestions were given during that, and actual ego strengthening was done, I think, after that one.
Okay. 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 And just again for my knowledge, what was her response after that, the dynamic imagery?
So ma'am, after
Particular
that,
thing.
sorry, ma'am.
Particular thing, if she has mentioned anything.
So she only thing she mentioned that she felt a calmness of mind and that the thoughts were not so much affecting her as that they were previously. That is the
Okay.
particular thing that she mentioned.
Okay, great. Great. Anyone else?
Dr. Dhruv,
Good evening. This is Ram.
Yes,
okay,
please.
okay, yeah, sure, sir. Rao, sir.
Yes, sir.
Please.
Sir, good evening.
Hello, sir.
I'm Subramanyeshwar. I'm a psychologist working at Government General Hospital, Machilipatnam.
Yes.
So, psychiatric department. Sir, in between these, I think 6 or 7 episodes were there. So, in between that, do you prescribe any medicine, sir? Because I think some anxiety will also be associated. I think so. For that, do you prescribe any medicine for
Sir,
that?
she was given Sertraline 25 mg HS SOS and along with clonazepam, sir.
Okay, but anyway,
Uh,
medication is there.
Sir, medication only for the first 4-5 days. So, sir, the hypnotherapy was initiated after 10 days of treatment, about 10 to 12 days of treatment,
Okay,
following which she was tapered and only one or two medication was continued for about the first 3-4 sessions, and everything was stopped after that.
that was also, I think, for controlling the anxious
Uh,
nature.
yes, sir.
Okay. Anyway, she was not any. She doesn't have that sleeping problems or appetite issues.
No,
So
sir.
probably yes. Yes. Okay. Thank you, sir. Thank you.
Yes, sir.
Anyone else?
Dr. Dhruv, I just wanted to ask that DSM-4 में तो it was separate ना conversion disorder. अभी तो I think we club it as DID, dissociative orders में disorders में.
Ma'am,
No?
if we talk about DSM, there are two aspects of that. There is one conversion disorder that has only a motor component,
हाँ.
and the other part of it has four disorders of consciousness, what we say, the personality, the fugue, amnesia, and the depersonalization, derealization. So
Yeah.
that is aspect of consciousness, and one is aspect of the conversion disorder, motor symptoms. So they are
Okay.
to separate in DSM-5,
Okay.
but
Okay.
in
DSM-5.
ICD-11 it has only the motor symptoms, the sensory symptoms, and the
Yeah.
autonomic loss. That
Yeah. Because I am asking this question because I know a few patients, uh, you're talking about the disorders of consciousness, wherein these kind of disorder, from point of view of client, they kind of sometimes use terms as possession or upri hawa types. it happens here in North India. So I was thinking कि similar kind का ही इस लड़की के साथ होगा. Yeah.
Ma'am, so the initial term of hysteria, which was given by Freud, it
हाँ.
had four consciousness now, four different consciousness which include now, that is dissociative fugue, dissociative amnesia, depersonalization, derealization, all this. So that comes in the consciousness aspect. One is the motor aspect, different, which has autonomic symptoms, sensory and motor symptoms.
Okay. Okay. Thank you for clarifying that. Thank
Yes,
you.
ma'am. No problem.
Yeah. Anyone else? Or anyone would like to add to this, their own experience treating a conversion disorder ka patient and all that. If anyone else is there, would like to share about that. Dr. Dron, all the
Yeah.
sessions are over. Like she is totally out of it. You are in
Totally
touch
out of
with
it. Yes, ma'am. No, it has been about 3 months since we have seen her
her?
last in
Great,
the OPD.
great, great. Wonderful. Any questions?
It was
Sorry.
during the exam only that I started taking up cases. I was not very confident initially, so it was during that time only I started taking cases.
Okay. Okay. So, was this the first case?
Actually, yes.
Great.
Previously, I could not I did not do all cases up to 5 because we didn't get that much time. But this
Yeah.
was the first patient that I've actually given tried to give about 7 sessions, about 8 to 9 sessions actually for the uh, taking out time and giving, because when they are in the ward we can not go every time to the ward to take sessions, so
Right.
it was a bit difficult.
नीरज, so far I remember, I think conversion disorder का अभी पिछले 1-1.5 साल में तो ये पहला केस है ना?
जो यहाँ पे डिस्कस हो रहा है actually. Yes.
है ना? हाँ. Yes.
So, because I was discussing this thing with Dr. Madhur Rathi here, so usually I think psychiatrists also do not want to apply hypnotherapy in dissociative disorders. They're like little hesitant. So I was like really happy that Dr. Dron presented this case. And I remember one of such cases of a high level of dissociation, वो है ना अपने psychiatrist डॉक्टर दमन एंड दीव में जो प्रोफेसर है
Daman and Dume, Dhaval sir.
धवल सर धवल
Dhaval sir
पटेल
is my head. Yes.
हाँ हाँ वो उन्होंने प्रेजेंट किए हैं ऐसे केसेस या ही इज वेरी गुड एट these things.
I work under sir in the same college,
ओह
the same
excellent.
hospital. Yes.
हाँ हाँ धवल सर ने तो पेपर भी लिखा है ऐसे एक
हाँ,
dissociation.
okay.
बहुत अच्छा. हाँ.
So,
I think we are not getting any more questions today. If
no
we
questions,
want
I think.
Sir, I have a small
to, Ina ma'am.
Oh, again, I'm sorry for the interruption.
हाँ जी
Yes,
डॉक्टर.
yes, we can
Yes.
continue.
Sir, actually, in my department also, earlier 2-3 times I was trying to initiate this hypnotherapy for dissociative disorder. But what my associate professor was conveyed that if we try for dissociative disorders patients for hypnotherapy, they might become a psychosis. So do you in between this therapy process, do you ever address such kind of any such that kind of symptoms or like things?
Sir, I would differ from that opinion that treating conversion or treating dissociative disorder or conversion disorder with hypnotherapy will lead to psychosis. Sir, psychosis is out of question in such patients, and if the patient is if though the patient is experiencing quasi psychotic episode, I would not initiate the patient for hypnotherapy, sir. So psychosis, if there is any episode of even slight suggestion of psychosis, I would not start hypnotherapy. It is not advised, sir. So, but for conversion disorder, there is no question of psychosis, sir, as of my experience.
Because 2-3 times
Also, I would
there
like
is
to add
like
here.
this response from my department, so that's what I'm.
Yes, sir. So
This
we
is
daily we see around a month about 4 to 5 cases of conversion disorder, sir.
okay.
There is no psychotic spells. Like if it is psychotic spells, we would not diagnose as dissociative disorder, sir. We would keep it as acute and transient psychotic disorder, ATPD,
Okay.
wherein we will not initiate hypnotherapy, sir.
Okay. Thanks. Thank you. Thank you very much.
Yes.
Also, I would like to add here, I think it's a misconception with respect to dissociative disorder, not giving hypnosis. For the treatment of different types of dissociative disorders, hypnotherapy is the most effective treatment modality as compared to any other therapy. And it doesn't get converted into psychosis.
Yes, ma'am.
Thank you, madam. Thank you.
Thank you.
Veena ma'am, would you like to, share your experience if you have treated conversion disorder? Would you like to share?
First of all, I'll congratulate Dr. Dron. It was a very well articulated, well made presentation. I don't have any question here, except that in the therapy sessions, the work was entirely focused on ego strengthening only. There was no therapeutic communication which happened.
Ma'am, majorly yes. Not much of exploration was done, ma'am.
No, not. I'm not talking about unconscious exploration. I'm
Okay.
asking therapeutic suggestion, therapeutic communication with the client in the hypnosis state, apart from ego strengthening.
No, ma'am, it was not done.
And despite you got very good
Very
result,
good
so
response. Yes, ma'am.
congratulations for that.
Yes, ma'am.
Okay, ma'am, we can end the session then today if we are not getting any more questions.
I think we should. I think, yes. Yeah. So thank you, Dr. Dron. It was really, really wonderful presentation. And we expect कि ज़्यादा से ज़्यादा psychiatrist इस तरह के case present करे, because there is a lot to learn from each of us, definitely each one, but then you people can add more, many things to the case. And so we look forward, Dr. Drone, that we look forward to another case from you. So it would be nice कि आप और एक case कभी present करें. So thank you so much for an excellent presentation. Thank you.
Thank you so much, ma'am, for giving me this opportunity. It's been my first time on this forum, and I'm really pleased with this opportunity and really honored to present my case in front of all the experts. Thank you so much, ma'am.
Thank you, thank you. Actually, Dr. Drone was very busy, and still you have presented. I know you had a very busy schedule. I understand that,
I actually
but
forgot the
really
thing.
I really
So,
thank you. Thank you
no, ma'am,
so
thank you
much.
so much, ma'am.
Okay, thank you, everyone.
Thank you, ma'am.
Bye.
Thank you,
Good
everyone.
day.
Have a
Thank
nice
you very
day.
much.
Thank you,
Yeah.
Dr. Dhruv.
Yes, ma'am. Thank you, ma'am.